from Brooklyn to the east side. Just, I wasn't able to pull it off. But I am here as a colleague of these two extraordinary alums, and as a longtime standing volunteer of the American Heart Association. There's the deck. There's the deck. Yep. So when we started practicing, I'll say Annabelle and I, and even more so for Dr. Wenger, we thought of the Heart Association as a truly scientific organization. They gave out money. It was started actually by a group of male cardiologists here in New York City. They are on their 100th anniversary, and it is the largest not-for-profit volunteer organization in the world. And it has evolved over our careers, in my eyes, to be a really extraordinary and inspiring organization. When I can speak to when Annabelle and I were starting, the organization was focused on eliminating heart disease and stroke. And that's how it started, and it was fixing disease. Over years, the American Heart Association evolved into preventive strategies, not just waiting for someone to get disease, but how can we prevent? And now, the final iteration of what inspires so many of us to volunteer is a focus on health equity, not only in the US, but around the world. And the mission I always find very enlightening, to be a relentless force for a world of longer, healthier lives. When the AHA came up with that, for those of us who started thinking this was the organization that funded our research to lower death rates from heart disease and stroke, to hear this, we thought it was really very inspiring. The AHA is the largest trainer of CPR, and all of us have seen in the media lately how easy it is to save a life and how much the cost there is to families and society in not saving a life. AHA has given out over $5 billion in research since inception. It gushes about 13 Nobel Prize winners and counting. It's a really inspiring organization to me. I'm going to go through this quickly because I know I'm between you and the end. The organization is national with initiatives and offices around the world, actually. They're Dallas-based. We are organized around 5 different regions. I can tell you quite proudly, because I'm involved in New York City office for the American Heart Association, is one of the most well-respected, sorry ladies, in the country. We live in an extraordinary place with magnificent universities, colleges, high schools, medical centers, research organizations, as well as a good commitment from our citizens to philanthropy. Next slide. And there was a theme a few years ago, we did that. So as clinicians, it's very exciting for us to see, and as practitioners, for all of us have seen the evolution. I trained here in New York City in the 80s, and what we could do then as cardiologists to mitigate the morbidity and mortality from heart disease and stroke was nothing compared to what we can do. And this is fundraising, research, trial and error, all of the things that are so second, place for us without thinking. Defibrillators in airports, CPR that high school students learn, but also activities against smoking cessation. So when we talk about the importance of public health, not just science in a research lab or at a major university, what I do in my office only impacts 20% of the health of my patients. Where they live, how they have their ability to eat healthy foods, to walk, to not be burdened by tobacco commercials everywhere we turn or salt commercials is important. And the American Heart Association and all of us in cardiology see that we need to be outside of our offices, and what goes on in our communities really matters. Next one. And so this is the impact goal, and the AHA talks about being a champion of health equity. And I would say cardiologists feel this way because we're still treating individuals with the #1 killer for men and women. Stroke, depending on the year, is either 3, 4, or 5. So these are diseases that we can't make go away. But because of preventive strategies, because of things like the essential 8s, we know that we can do more. And we know that there are areas around our country and around the world that don't have equivalent access. And I think that that is a foundational value of the AHA. like these. I've been involved since fellowship here in New York. These are, again, inspiring to me. Improving and extending life, speaking with a trustworthy voice for all of us who watch the world of COVID, not over yet. The importance of the way we trust and hear science is very important to cardiologists and the American Heart Association. Inspiring commitment, ensuring equitable care, bringing science to life, making an extraordinary impact, meeting people where they are. Again, coming to my office isn't always the most important thing, and partnerships. And the AHA sees itself, as all of us do who practice cardiology or do science, as catalysts to align and amplify other work. And these are the, the current priorities in the nation, but here in the New York City Heart Association group, we focus on Go Red, as you heard so eloquently from the work that Annabelle's done and Dr. Wenger truly started for all of us. Addressing community needs, and every community is different. What works in rural upstate New York is not going to work in the Bronx. What works in Idaho is not going to work in New York. And so this really has to be personalized and customized. Tobacco and vaping is something we thought that we'd gotten away from, 1950s, 60s, and 70s, and now vaping is here. And this is a priority of ours because we see the prevalence in young adults of tobacco use, vaping, thinking it's safe, and knowing that one of those cartridges has the nicotine of an entire pack of cigarettes. And when I speak to high school students, they're astounded by that fact. And I am astounded by the prevalence of vaping and by the sneaky ways that people do it. I am the daughter, my late father was a middle school principal. If he knew about sweatshirts where you put things, Fourth, controlling blood pressure. It's the end of the day, aside from cigarette smoking, it is the most modifiable risk factor. So for any of us who think, I have a little bit of high blood pressure, it's borderline, I had a bad day, doctor, no. That is the one thing that we can have an enormous impact. It's more important in blacks than whites. It's more important in those who are overweight or diabetic, as Dr. Wenger said. All of these kind of overlap. And then finally, food insecurity and promoting well-being in a world that is very, very stressful. Next. And we know the barriers. Social determinants of health is a new term. We were not taught this in med school, and it goes back to what we've learned from population and public health, that where we live, school, eat, breathe, laugh, pray, matters much more significantly. And education matters, access to physician, access to foods, clean water, all of this matters, and it's no longer, when the American Heart Association and the American College of Cardiology started focusing on this, I had colleagues who said, well, this isn't my lane, Stacy. I'm a doctor, I go into a room, I go into an office. But all you have to do is see patients for not that long, and you know that if you can't purchase the drugs, if health literacy is an issue, and none of it matters what goes on in my office. So to the American College of Cardiology, the American Heart Association, this has become one of our driving themes. Structural racism has been taken on not just over the last few years, but science has shown us that this is something that can't be ignored or written off. And rural health disparities, it's interesting, I've only trained and worked in cities before going out to Long Island, and particularly in New York at two major municipal centers and some hospitals. And I thought that those were the most challenging. I've never practiced in rural America, and when I speak to friends who do, the challenges there, quite frankly, are equivalent to, and in some cases worse. And so a focus on rural America has been our priority as well. These are commitments to health equity. I don't need to read them to you. The AHA is giving a lot of money toward this. It is giving it in a way that's not just science in a lab or in a clinic, but implementation science, something we know that we know what to tell patients to do. Why don't they do it? Why don't we get patients to take the med? So understanding how we turn science from, we say, bench to bedside is very important. The next slide is just the last of these. Again, I'm happy to share. Next. The Go Red movement is exciting for all of us, and we've got our clothing on. If you'd like, I'm going to have Dr. Baldwin send you a picture of her closet in February. She walks the walk. We realized from the slide that Dr. Volman showed you that what we trained on thinking was a man's disease was killing more women, and a lot of reasons. Dr. Wenger said we didn't study women, we explicitly excluded them. Sociologically, women take care of their families, and I'm too busy for my fill-in a blank checkup, mammogram, blood test. Women are unheard and underestimated by what was a pretty patriarchal health system. So all of that had to change. And the Go Red movement realized that we need science, education, advocacy, and patients as partners, as Dr. Wenger said, to demand better care. One is too many is the manifesto. It is a fun organization to be involved with Go Red here in New York City. There are opportunities for as early as middle schoolers and below to become involved with this. In previous years, we had Hoops for Heart and other things, but now there's a very, particularly here in New York City, a very robust set of opportunities for middle schoolers, high schoolers, et cetera, to volunteer. And it is never too early or too late to start doing some of the changes that Dr. Wenger spoke about. And no amount of going in the right direction isn't enough. You don't have to run the city marathon next week. Walking to your neighbor's desk instead of calling, maybe not using the elevators, 250 calories in and out. All of those things are things that are manageable. Sociologically, women have a tendency to, if we don't do it perfectly, we don't want to do it at all. So you open up the cookies, you have one, figure, I'm going to have them all. I'll drink the whole sleeve. Have one cookie and, give yourself a break. It's all right. We encourage women to be aware as young as teenagers. We want to help women, so I tease women, you need to go for your checkup, you need your blood pressure checked. Bring someone with you. We know things like Weight Watchers work because of the staff, the support that you get. So be somebody's buddy in the Go Red movement. We need STEM activities, right? There are still, cardiology, our field, is still fewer than 20% of US cardiologists are female. It's kind of unacceptable. And if you put that next to the fact that 50% of our medical school grads are women, this isn't not something that's just unfair. It's something that's going to be a talent drain because we will not have the best and the brightest going into our fields. And lastly, addressing inequities in access and quality of care. CPR, just to go through, New York State, after a lot of fighting, finally requires it for high school graduation. I'm not sure if all schools or some are exempt. Could you imagine that was a fight? Yeah, I don't remember a lot of Shakespeare, but CPR has been used multiple times. It's so easy to be, and I'm happy to introduce the New York AHA people to the Hunter High School, College High School group to be sure that all of the access is here. Terrific. And we want a nation of lifesavers. We've seen too many, public opportunities where the outcome was extremely different, almost heart-wrenching. I think that's it. The last slide, just to share with students our opportunities to volunteer here in New York.
So I would like to thank such a gratitude about this opportunity for our alum, who are, as we know, lifelong learners. These women here and everyone in the room and everyone at home, you are, and we are so grateful that you would take time today to join us. Yes, our high school students do have to pass CPR in order to graduate, so know that. Know that we also have trainings for our faculty on the AIED machines, right? See, I don't have my abbreviations, but I know what to do with one. That's the important thing. And I want to thank the partnership with the AAHA, which we do use their resources and our students do volunteer with. but also the Alumni Association, for Alumni Association, bringing these extraordinary women to us. And I know that their legacy is something that Hunter is so proud of, and we're so grateful for all of your time and your efforts today. I want to acknowledge that the PTA is here as well. They have been partnering with our alumni, and this is part of how the whole community can continue to grow and for us to benefit from our relationships while we're a student, while we're a teacher, while we're a parent of a student, and while we're a graduate who's moving out in the world to take care of our hearts and that which is in our hearts, which is Hunter. So I thank you, ladies, so much for today. I understand we're open for questions. So if, do you want to read? How do we do
Yeah, I have
this?
a question from our
Sure.
stream.
I'll repeat it so it goes into the mic.
Thank you. One of our streamers want to know, what does Dr. Winger think about the new drugs being used for weight loss?
So Dr. Wang, what do you think about Ozempic and some of these, I said the name, the person did not, drugs used for weight loss?
The initial studies on these drugs have been very dramatic. But some of the problems that we're beginning to see with them in terms of problems with the intestinal tract, with delayed emptying of the stomach, etc., are being seen more when they're being used as weight loss drugs than we saw when they were being used as diabetic drugs. Now, whether this is a variable related to physician supervision or lack thereof, whether perhaps there is overuse of these drugs by the weight loss population, we will know this in the years to come. They are very effective weight loss drugs. They must be continued. The minute they're stopped, the weight loss stops, and the bad habits that cause weight gain may resume. It should be done not independently, but with the cooperation of a physician. But remember, these are new, and the profession is in its learning curve about these drugs as well.
Thank you. Are there any other questions? Yes?
So, kids or people under the age of 35 think they're invincible and they don't have to worry about heart disease. What do you tell them that they can start doing right now?
So I'm just going to repeat that into the microphone for a moment. The question is, since people under 35, particularly Hunter College high school students, might think that they are invincible, what should we know about healthy heart care for young people?
So I'm the mother of 3 of those individuals between 25 and 32. What's quite interesting is what we tell my children and others is to have a clinician, honestly, because I think the partnership that Dr. Wenger spoke about, so for women, it's often their gynecologist. So the cardiology world and our OBGYN world have strengthened our partnerships. Firstly, my 2 daughters go to a gynecologist as their only doctor, and I asked, are you asked about our family history? Are you, were you told to bring in your personal history? No, it was a GYN exam. So some of us, from a strategic point of view, are working for the females to really partner so that OBGYN visit or GYN visit becomes more of a well-woman visit, which includes all of this. For the young men, we let them know that prevention is everything, and that the earlier you start, the more likely you are to have good habits. But it's difficult.
Can I just add? So it is hard to convince teenagers about how to eat healthy for your heart, but we do need to teach them how to be heart healthy, starting at their teenage years. There was a study of Korean soldiers who died, and they were teenagers. They were 18-year-old men who died in the Korean War, and when they did autopsies on these young men, they already had the beginning of plaque in their hearts. So it starts at an early age and it just gets worse, especially in people with family history of heart disease. And as you saw in Dr. Wanger's slides, there are certain populations such as South Asians, Filipinos actually also have very high risk, African Americans have very high risk of heart disease and strokes. So those people need to be aware that it can start at a very young age. There are certain populations such as people with heart disease or familial hypercholesterolemia, where their cholesterol can be over 300. The LDL cholesterol can be over 300, and they can have heart disease and strokes in their teenage years. So those people hopefully are being followed, very closely already. But like Dr. Rosen said, have a good primary care physician who understand that it starts early and we need to start them at a young age.
Well, many, many years ago, the Heart Association had a program called Heart Health Education in the Young that was part of the grade school curriculum. The children were given primitive stethoscopes and blood pressure cuffs. They were taught how to measure blood pressure. They took those blood pressure cuffs home and the stethoscopes, and suddenly the parents learned about blood pressure, they learned about measuring it, and this was an extension of the education program. Now, sadly, that program has faded away. I think we need to restore it. But we need to have a heart health education program beginning in the grade school, because first we have to take a look at the school cafeterias. Do they promote or do they promote health or exacerbate disease? You need choices, but they should be healthy choices. We've been very fortunate in the US that for most populations, smoking is not considered socially acceptable. But vaping now is, and we need a program against vaping that is as effective as our program against smoking. But when we remove physical activity from the schools, we remove something that was very important in education, and that has to be restored. And then we have to restore to our total educational program health issues. And for men and women, heart disease remains the leading cause of death. Now, this age group, and I would say not even 30, 20 to 40, 20 to 50, some of it is our problem as professionals. Because years ago we said you don't even start screening for heart disease until 50. And then we took it down to 45 and 40. I see patients in my intensive care unit with a heart attack at age 35. Now that is a potentially preventable problem. And I think we need to work with our pediatricians. What most of the pediatricians don't appreciate, and what we need the mothers to appreciate, is that if they have had one of the complications of pregnancy, hypertension, preeclampsia, diabetes, their children are at increased risk of heart disease, and they should share that information with the pediatrician. So we need to get the pediatricians involved in heart health, because that's where it begins. And the American Heart Association has a partnership with the Association of Obstetrics and Gynecologists. The OBGYNs are in the preventive mode. What are they doing? Pap smears and mammograms. But they're not addressing the #1 issue for the women they see, and that's their heart health. And we really need them either to do the heart disease screening or to refer. So we need partnerships. We need to stop having medical care siloed.
Thank you so much. Got one more question.
This is for the entire panel. Someone says recent research from NIH suggests premature arterial contractions may lead to arterial fibrillation, but may also be an independent risk for stroke in absence of arterial fibrillation. They want to just know your perspective on that.
I'm not going to repeat that question because I will An English teacher would not get that right. So I'm gonna
Thank
let
you.
you repeat that.
Since I'm a rhythm specialist, I will answer that question. So the question was whether premature atrial contractions, which are one beat that's early that comes from the upper chamber of the heart. If you have a lot of those, it can lead to what we fear is atrial fibrillation. Atrial fibrillation is the most common arrhythmia in the country that can lead to strokes and heart failure. So we want to prevent that, and there are many ways to prevent it. One of the biggest cause of atrial fibrillation is high blood pressure. So make sure your blood pressure remains low. As Dr. Wenger said, it should be less than 130/80, but preferably less than 120/80, actually. You start seeing cardiovascular risk starting at anything above 115/70. So our goal is to, with our medications, is to lower it to less than 130/80, but as a healthy person, you want your blood pressure to actually be about 115/70. That's what I keep telling my patients. I go, really that low? It's like, yes, really that low. So preventing atrial fibrillation, also, so this is one of my favorite topics because as I said, I'm an arrhythmia specialist. And we just found out why men have more atrial fibrillation than women. And it's all about the height. They're just bigger than us. They're taller than women, and that actually increases their risk. So if you look at age-matched groups, men will always have a higher risk of atrial fibrillation. But because women live longer, and the older the women are, they have more risk for atrial fibrillation. There are actually more women with atrial fibrillation than men in the country. So that's always very confusing, but I just want to make sure that people understand that it's a risk for both men and women. So one of the wonderful ways that we can decrease the risk of stroke is really easy. You just need to take these medications that can really markedly reduce the risk by 80% in some people. So you can reduce the risk of stroke when you have atrial fibrillation by just taking medications that are blood thinners, and they're really great drugs at this time. The other thing that it can cause is heart failure, and you can reduce that risk by just lowering the heart rate, lowering the blood pressure, and there are some amazing new drugs for heart failure. That can also lead to atrial fibrillation, so you want to treat the heart failure very aggressively. And one of the great things that have come out of the new diabetes medications are these wonderful drugs that can really lower the risk of heart failure. So not only do those new diabetes medications make you lose weight, it can actually treat heart failure very, very well. And when they use these new medications in patients with diabetes, it reduced the risk of heart failure and therefore the risk of atrial fibrillation in these patients. So great new drugs that have really come to market recently that we're very happy that we have, because it's probably the first time that my patients are coming back to me and saying, thank you for putting me on that new drug. It makes me feel so much better. I breathe easier, I can do more. So I'm so happy that we finally found diabetes medications that can really reduce the risk of heart disease. So I'm really happy about that.
I think one thing, just to follow up on some of the things that Dr. Bowman says, one of the things that you have to realize is that medicine changes. And if your physician told you something 2 or 3 years ago, and then you come back and you hear something new, listen to it. Because when I think of the medications that I use day in and day out in clinic, 95% of them had not been invented when I was in my training. And of the newer ones that are some of the most exciting life-saving drugs, they were not on our spectrum 25 years ago. So please appreciate that medications change, regimens change, tests change. For example, Years ago, if you had a heart attack, every year you would get test A, test B, and test C. And you'd come back to the doctor after these elaborate tests, and you were told they're normal, but they'd be ordered again the next year. And now we're not doing them anymore because we found that they're not necessary unless you have symptoms. So things you were told 8 and 10 years ago may not apply in 2024. The world changes, medicine changes, the recommendations you get change. So listen carefully, and if you don't understand why, ask.
And that is a wonderful, wonderful reminder to everyone that questioning what we have known, what we need to know, is going to be the answer to how we move forward. So if I can ask everyone to please thank Dr. Vogel and Dr. Wenger and Dr. Rosen for their time, for their wisdom, and the Alumni Association for what a wonderful day. So thank you so very much.